Hello, everyone. My name is Jonathan Spicer. It's my pleasure to be here with Dr. Nasser Al-Torki, talking to you about whether the addition of immunotherapy to multimodal management of stage 1 to 3 non-small cell lung cancer can help break the stalled cycle of poor outcomes. So it really is a privilege today to be in Dr. Al-Torki's company from Weill Cornell Medical College in New York, and I'm joining you here from Montreal, Quebec. I think if we've learned anything from the last 30 plus years of care in this area, is that the best outcomes are achieved via multimodality approach. But what has been striking is the rapid number of changes and new data emerging in the last 5 years. And these have really been thanks to novel therapeutics that have proven their value in the metastatic stage, now being applied to resectable stages of disease. And so immunotherapy is becoming a pillar of treatment in operable lung cancer, which is obviously very exciting, and we all have a tremendous amount of hope about how it could positively impact our patients. So to structure the discussion today, I'll be focusing on the role of neoadjuvant immunotherapy, and Dr. Al-Torki will discuss the recent Empower 010 results, focusing on adjuvant immunotherapy. We'll then go on to do some case discussions to try and illustrate what have emerged as many of the questions people have about how to manage these patients. So starting with neoadjuvant immunotherapy, conceptually, although it's not a commonly employed approach either in North America or Europe or many places around the world, there are some strategic advantages to neoadjuvant therapy. Knowing that most of our patients who do recur will recur with metastatic disease, the idea of addressing that metastatic disease with early application of systemic therapy is attractive. Immunotherapy has the benefit of inducing a T-cell response that is targeted against neoantigens present in the tumor, and with the tumor in situ during the application of immunotherapy, at least theoretically, there's perhaps a greater opportunity to generate these T-cell specific responses. There is data, although it's not prospective or comparative, but there is data to indicate that neoadjuvant therapy may be better tolerated than it is in the adjuvant setting. There are issues of attrition and stage appropriate patients not making it to adjuvant therapy even when indicated, and we've all known this for a long time. And then there's all of the translational and scientific benefits of a neoadjuvant regimen, which are unparalleled really in terms of accessing pre and post treated tissues and trying to determine predictors of response. So for all those reasons, I think there's a lot of enthusiasm about this approach. Now, that being said, there are certainly some concerns, and I think surgeons are amongst the most concerned because we truly look after the highest risk portion of the patient's trajectory with their operative intervention. And we don't want to compromise that any further or increase risk to our patients, when we also know that that's what contributes the greatest portion to the possibility of cure. So questions that come up are, which patients do we include, and do we really have to do this? What is the optimal duration, or what are the optimal combinations of neoadjuvant therapy? What kind of side effects can we expect for our patients, or are the oncologists going to mess this up? And this is sort of nicely summarized in this great expert opinion piece by your protege, Dr. Al-Torki, Brendan Stiles, Boris Pesci, Stephen Broderick, and Matthew Bott. It's a good read. We also need to figure out how to assess clinical response because it might impact our surgical decision-making. How do we approach these patients surgically, MIS or open? And will it increase the complication rate? Is it going to affect our statistics, which is obviously a concern. We all want good outcomes for our patients. So this all really started with a small series of 20 or so, 22 patients that were treated at Hopkins and Sloan Kettering with 2 doses of preoperative nivolumab. And right away, even if this was a small trial, I think everyone was struck by the very impressive pathological response data that emerged from that trial. And it really ushered in a whole host of new trials, and there's dozens more that are going to be reporting in the coming years, investigating different regimens, different doses, different approaches. And it's been hard to integrate all of that information as it's been thrown at us very quickly. But one thing that's been consistent is that what we see on the scan does not always correspond to what we see pathologically, and can sometimes be hard to appreciate how it might influence our surgery. So we had some great responses that still had in the tumor that still had residual nodal disease, other patients where the tumor may have appeared to grow, but then in fact had almost complete pathological response. So how do we manage all that? It's a big question. But all that early data has led to a flurry of activity, and pretty much every company that has a checkpoint inhibitor in their profile is doing these either neoadjuvant or periadjuvant trials. And it's almost unquestioned that this will become part of our day-to-day practice before long. So I had some involvement in Checkmate 816, which is a trial that investigated the use of neoadjuvant nivolumab plus platinum doublet versus platinum doublet chemotherapy for stage 1B to 3A by the old HACC 7 criteria. There was a nivo-ipi arm, which is yet to fully report out, but that was dropped when the results of the Nadine trial started to come in, indicating that nivo chemo was probably the most efficacious and well-tolerated regimen. The primary outcome measures for this trial were event-free survival and pathological complete response, with some other exploratory and secondary outcome measures. The baseline characteristics of the patients were fairly well balanced, exactly what you would expect from predominantly stage 2-3 patient population. Half the patients were recruited in Asia, and they were about evenly split between squamous and non-squamous histologies. This is the flow diagram for patients making their way through the treatment trajectory in the trial. And as you can see, the vast majority of patients were able to at least start neoadjuvant chemo, and most were able to complete. In fact, more seemed to be able to complete it in the chemo nivolumab arm. There were some surgical cancellations, which always calls into some concerns. But in fact, the amount that were due to disease progression, it says 7% and 10% here, but radiological progression by RECIST criteria was only 1% in each arm. One finding which I thought was compelling as a surgeon is the duration of surgery. So we have almost a half-hour difference in the time of surgery between the two cohorts favoring the nivo chemo arm. And this was held up across stages. So even in the stage 1B and 2s, the surgical time was less. The impressive finding was the positivity of the first independent primary endpoint, which was pathological complete response. And you see a delta of almost 22% between chemo and nivo chemo, or 14-fold difference, which was no doubt dramatic. This was particularly interesting in that it was true across all predefined subgroups analyzed, and there did not appear to be any really significant influence of the PD-L1 level, which is also consistent with what we've seen in the metastatic stage. but perhaps even more so in these earlier stage patients that may have a more intact immune system and better able to respond to checkpoint inhibitors. So the other thing that I've noted, which I think will be important to investigate further in the future, is that although a smaller proportion of patients were exposed to carboplatin containing regimens versus the standard, which is cisplatin, the response rates seemed very, very good. And if there's one difference between CheckMate 816 and the results of the NADIM trial, where we saw over 60% pathological complete response, is that the chemo regimens were quite different. Cisplatin being the favored doublet in CheckMate 816, whereas carbotaxol was the regimen used in NADIM. Depth of pathological response was impressive and dramatic as compared to chemo, and this was true across stage groupings, as you can see here. And so really, regardless of stage, there is extreme biological activity of this combination as opposed to chemo alone. When one looks at the adverse event summary from the neoadjuvant portion of the trial, there were really no signals to indicate that there was increased adverse events in the nivo chemo group, which is unusual when you add an extra anti-cancer agent. So that was very reassuring. There was an exploratory analysis looking at ctDNA clearance, and this provides us with some hope that it could be a useful biomarker to predict the occurrence of PCR. Further studies will have to be done to determine that more clearly. From a surgical standpoint, I think it was exciting to see that this neoadjuvant regimen could reduce the amount of thoracotomies required, particularly in the stage 3A patients, where this is, more surgeons may be approaching these open, especially in a multi-center trial that's conducted over 150 sites. You have to remember that these surgeons were perhaps seeing this regimen for the first and only time in their career if they only recruited 1 or 2 patients. So you can understand why a lot of them might have approached these patients by an open surgical technique. The conversion rate was almost reduced by half by the application of nivo chemo, which I think is also quite telling. To me, this is, from a surgical standpoint, one of the most impressive and important findings. We have 20% more patients in the stage 3A cohort that are able to have their resection done via a lobectomy. Maybe 40% fewer patients requiring pneumonectomy, again in the stage 3A cohort, which is, to me, very meaningful from a morbidity and tolerability perspective on the surgical side. When we look at the outcomes, the most striking one is less pain in the nivo chemo treated cohort, most likely due to the reduced rate of thoracotomies. But there are other adverse events like dyspnea or fistulas that seem to be less frequent in the nivo chemo arm. In CTCAE, which is the clinical trial adverse event guide, grade 5 surgery-related events have to happen within the first 24 hours of surgery. As we know, surgeons, we consider 30 and 90-day outcomes to be all potentially surgically related. There were 2 grade 5 events in the nivo chemo arm versus chemo alone arm, and we hope to be able to report the 30 and 90-day mortality rates once the EFS is published. Length of stay, I think, was there was no difference when we looked at the whole cohort, but we know that length of stay is quite different based on where you live for a whole host of reasons. But when divided up by geographic region, there did seem to be a consistent and sustained reduction in the length of stay when patients got nivo chemo. And again, I think that's quite meaningful. So in summary, we know that CheckMate 816 has now met both of its co-primary endpoints of EFS and pathological response. There were no real specific subgroups that derived more benefit than the other. And from a surgical standpoint, although we weren't allowed to test for it, statistically, it does seem that the combination treatment is favorable versus chemo alone. This is not really news to many oncologists. Neoadjuvant treatment in breast cancer, melanoma has now become standard. And if you just look at the delta here between placebo plus chemo versus pembro plus chemo in the pathological complete response metrics, they're only about 13%. And that translated to a statistically significant event-free survival in a population that already has much better survival than our patients. So I definitely expect that the EFS will be clinically meaningful in terms of how positive it is. And we have to remember that our oncologists are keen to apply these types of treatments because they've seen the benefits in other disease sites in the past. So again, summarizing, I think it's clear that surgical resection after neoadjuvant chemoimmunotherapy is safe and that MIS techniques can be applied with relatively low attrition. That when we operate within our usual intervals after neoadjuvant chemo, meaning 4 to 6 weeks, chemoimmunotherapy leads to good surgical outcomes that aren't really significantly different from what we might expect from chemo alone. And really, surgeons, I think, can and should be willing partners to oncologists in terms of establishing the best possible care plans for their patients. So that's it for me. Happy to turn over to you, Dr. Al-Torki.
Thank you, Jonathan. That was a great presentation, great trial, and I'm pretty sure it will, given the event-free survival rate, it will soon be approved as a new regimen in patients with early stage lung cancer. That's really good results. So I want to just talk a little bit about adjuvant immunotherapy, which is the other side of this coin. And as you all know, there's a recent publication of the Empower-010 of the adjuvant use of atezolizumab in patients with completely resected stage 1B to 3A non-small cell lung cancer. What is the rationale for adjuvant therapy? Well, it addresses an important concern that surgeons and patients and referring physicians have, which is waiting. We don't want to wait. Patients don't want to wait, and the referring physicians certainly don't want to wait, lest the tumor progresses within the usual 9 to 12 weeks that are required to deliver neoadjuvant chemotherapy, for example. And then we also worry that the adjuvant therapy may actually make the operation more technically complex, increase the morbidity, and perhaps even reduce the chances of being able to do this operation minimally invasively. And the example that comes to mind here is the use of neoadjuvant chemoradiation, for example. And then, there is good reason to suspect that if you're going to apply, well, first of all, we have a track record of adjuvant therapy working for this disease. The adjuvant chemotherapy trials that have shown unequivocally that chemotherapy improves survival in this cohort of patients, albeit not great, 5 to 8%. And then finally, of course, is that there's the possibility that immunotherapy may be working better if you reduce the overall disease burden and the antigen load. So these are the real concerns, with the first two being the most important ones. So as the trials with early stage disease, with advanced stage disease, showed sequentially that the immune checkpoint inhibitors work in patients with stage 3 and stage 4 disease, the next logical step was that there were many trials led by industry exploring their benefit in the adjuvant setting. There are 4 of these trials: the ANVIL trial, which employs nivolumab; the Empower-010, which we'll talk about today, led by Genentech Roche; the NCI Canada BR31 trial of adjuvant durvalumab; and finally the PEARLS, or the Keynote 091, which employs adjuvant pembrolizumab. Generally, all these trials are applied in the same stages of disease, stage 1B to 3A, and have roughly the same primary endpoints. 2 of these trials have already reported, and the others are expected to read out in the next few months. So let's shift out to Empower 010, which is the first trial to report, and it was reported by Dr. Wakely, the results in ASCO of 2021, and an encore presentation about the surgical aspect of it was reported at the NSCLC. So this trial enrolled completely resected patients with stage 1B to 3A non-small cell lung cancers based on the AJCC version 7, stage 1B tumors that were more than 4 centimeters. The patients were enrolled but not randomized until they received their adjuvant chemotherapy. So 1,280 patients were enrolled, and then after chemotherapy, 1,005 patients were randomized 1-to-1 to receive 16 cycles of atezolizumab or best supportive care, which is basically observation. Patients were followed for survival. And the statistical analysis employed a hierarchical testing plan, meaning patients where disease-free survival, which was the primary endpoint, was tested in the primary population of PD-L1 positive stage 2 to 3A. And if it was positive, favoring atezo, that is, in that cohort, then the DFS was then assessed in all randomized stage 2 to 3A population. And if it was positive, then DFS was then tested in the overall population that included stage 1B as well. And then finally, overall survival. So as I said, the primary endpoint was DFS in the PD-L1 expressing stage 2 to 3A, and in all the randomized stage 2 to 3A, and in the ITT population. There were some secondary key endpoints, notable among them DFS in tumors expressing PD-L1 in 50% or more of the tumor cells. So the results were read out in the first interim analysis, and this just shows you the baseline characteristics, which are essentially similar between the atezo arm and the best supportive care arm. There was a slight preponderance of non-squamous histology, which was about a little over 60% in both arms of the trial. There was no difference in the proportion of patients who were PD-L1 positive by the SP263, being 57% in the atezo arm and 52% in the best supportive care arm. This was predominantly a stage 2 to 3A trial, with roughly 11 to 12% of the patients having stage 1B. The majority of the patients received a mediastinal node dissection, the rest having their nodes sampled. Again, the majority had positive nodal disease. Lobectomy was the most frequently done operation, done in 77 and 78% of the patients, and pneumonectomy was performed in a proportion that is common in these global trials. And then, of course, we mentioned that patients received up to 4 cycles of chemotherapy. The most common doublet was the cisplatin vinorelbine, followed by the cisplatin pemetrexed combination. The results, the DFS results in the primary population of PD-L1 expressing stage 2 to 3A were presented by Dr. Wakely, as I said, in ASCO 2021. And on the left side, and the left Kaplan-Meier here, you see that the survival favored the atezo arm, which was 60% in the atezo arm versus 48% in the best supportive care arm. The median disease-free survival was not reached after atezo and was 35 months after in the best supportive care arm, was a hazard ratio of 0.66 and a p-value of 0.004. When you looked at the all randomized stage 2 to 3A patients, again, DFS was significantly higher in the atezo arm. The median DFS was 42 months in the atezo arm versus 35 months in the best supportive care arm. The hazard ratio was 0.79 and the p-value was 0.02. In the overall population, which is the graph on the far right, there was an indication that the atezo arm fared better, although the statistical significance boundary was not crossed at the first interim analysis. So the DFS in the ITT population continues to be followed until the final DFS. This is a forest plot that which is an exploratory analysis that shows the DFS in the population of patients that were stage 2 to 3A that expressed PD-L1. And here, basically, the take-home message, this is an unplanned exploratory analysis, and the take-home message is that in the left side of the line, to the left of the line is favoring atezo. So atezo was beneficial across all key demographic and clinical characteristics. It's important to note here that at the time that these adjuvant trials were set up, patients with EGFR mutations and ALK rearrangements were included. And even though it seems like the hazard ratio here is to the left of the line in the EGFR population specifically, the numbers are way too small. And generally speaking, these patients are no longer treated by immune checkpoint inhibition. This is another, the same exploratory analysis, but now applied to all randomized patients with stage 2 to 3A. And again, it shows that the atezo improved DFS across all key demographic and clinical characteristics. Importantly here, within the outlined box, you can see that the benefit was restricted to patients who had PD-L1 expressed in 50% or more, or any PD-L1 expression. I will draw your attention that in the DFS in patients with 50% or more expression of PD-L1, that's a key secondary endpoint. And if you look at this hazard ratio, it's 0.43, which equates to, I suppose, to be a 57% reduction in the hazard of death. These are the data that I just showed you with regarding to PD-L1 expression and DFS, just shown graphically here. In the top 3 panels are the DFS in patients, including those that have EGFR mutations and ALK rearrangements. And again, you can see that in each one of these arms, the DFS was significantly higher, better than the best supportive care arm, certainly in the whole target population that expressed any PD-L1, and certainly in the key secondary endpoint of PD-L1 more than 50%. The PD-L1 expression between 1 and 49% was not a pre-specified endpoint, so it's sort of hard to draw any meaningful conclusions, but you can see that the DFS was still better in those patients and was numerically higher when we excluded patients who had EGFR mutations or ALK rearrangements. So in general, across all levels of PD-L1 expression, there seems to be a beneficial effect across the board here. We then looked at, and this is some of the data that was presented at the ISLC meeting, the impact of prior therapy on DFS in the target population expressing PD-L1 in 1% or more, which is the stage 2 to 3A patients. And again, I remind you that to the left of the line favors atezo. So in general, across all treatment types, all surgical treatments, all types of chemotherapy, there was generally favored, DFS was generally better after atezo. There was some discussion about whether or not patients with pneumonectomy should benefited, or patients who received cisgem had a benefit or not. And I think it's important to keep in mind that these are exploratory analyses, not for which the trial was not really powered, and therefore the hard conclusions cannot be drawn based on these small numbers. There was also an exploratory analysis looking at circulating tumor DNA positivity and how it was cleared. And here, these graphs show that circulating tumor DNA was an important prognostic sign, both in the atezo arm and in the best supportive care arm. So if you look here, the 2 blue lines represent the atezo arm, and here is survival with atezo in patients who cleared their circulating tumor DNA versus those that did not, and that was statistically significant. In the best supportive care arm, as you would expect, patients who had residual positive circulating tumor DNA did worse than those that were negative. In a direct comparison, median disease-free survival was better if the DNA was cleared, which is these two curves here. So if you cleared your circulating tumor DNA, you still did better with atezo than without, and you still did better with atezo than without if you had residual circulating tumor DNA. And then the issue, of course, was what are the adverse events? Do we take patients who had just finished chemotherapy and then give them an additional 16 cycles of immune checkpoints, and what is the downside of that? And the grade 3-4 adverse events associated with atezo was 21%. About half of those were considered to be treatment related. There were 8 deaths in the atezo arm. 4 of them were considered treatment related. 1 was from interstitial lung disease. 1, I think, was from a cerebrovascular event. 1 from acute leukemia. And the other one, I think, was from a myocardial event. So among 495 patients, there were 4 deaths that were deemed to be related to that, to the treatment. What about the immune-related adverse events? Well, as you would expect in the active arm, there were a lot of immune-related adverse events among the patients who received atezo, which was 51% versus 9.5%. And these are immune-related events of any grade. But what are the common ones? The common ones were rash, transaminitis, and hypothyroidism. As you can see, mostly grade 1 and 2. The grade 3 and 4 events were very infrequent and were in the low single digits. One thing that is of concern to us as surgeons is the proportion of patients who would develop immune-related pneumonitis with the therapy. And as you can see, pneumonitis of any grade occurred in 3.8% of the patients who received adjuvant atezo, and in only 4 patients was it a grade 3 and 4 events and a grade 3 or 4 adverse event. And I think only 1 of these required intervention. This is just looking at the overall survival, which, as I said, was not the statistical significant boundary was not crossed. And this is in overall survival in the stage 2 to 3A PD-L1 expressing tumors, all randomized 2 to 3A and in the ITT population. Now the trial continues until the final interim analysis to report on overall survival and DFS in the ITT population. The trial led to an FDA approval of atezolizumab for adjuvant treatment following resection and platinum-based chemotherapy in stage 2 to 3A, whose tumors have PD-L1 expression on 1% or more of the tumor cells by the FDA. That has to be shown using the Ventana PD-L1 or the SP263 assay to show positivity for PD-L1. And recently, of course, there was a press release from the Pearl trial showing that adjuvant pembrolizumab met its primary endpoint of improvement in DFS in patients with stage 1B to 3A following surgical resection, regardless of PD-L1 expression. But in the co-primary endpoint of PD-L1 in tumor proportion score more than 50% or more, although there was an improvement in DFS, the difference was not statistically significant. So the trial continues the patients continue to be followed for that co-primary endpoint. And I think that's all I have.
Thank you so much, Dr. Al-Torki. That brilliant study, and what an achievement to bring this new treatment to so many patients. It's transformative and a long time coming. So we've reserved the last 20 minutes or so of this presentation to go through some cases in hopes that we could address some of the questions that have come through from different registrants and folks we speak to on a regular basis about managing immunotherapy in the perioperative setting. So Dr. Al-Torki, I'll present, this is a case I've yet to operate, and I'm curious to have your insights. He's a 71-year-old patient who is an ex-smoker with 50-pack-year history of smoking. He presented at the time with ECOG 0. He had a bronchial biopsy showing squamous cell carcinoma that was PD-L1 90%. Clinically staged him as a T3N0. He had good lung function. Quantitative VQ showed that his left lung was contributing 35% function. So my questions to you would be, how would you manage this patient in your practice? We can see that it's a very avid lesion here in the hilum with encroachment of the proximal left main PA. Would you favor a neoadjuvant approach, surgery first? Would you need more information? How would you approach the situation?
Yeah, so I think this is a case in which given the proximity and the abutment of the tumor on the PA so proximally, is the patient would be likely to have a pneumonectomy in order to get it out if I would do surgery first. Now, you may be able to do something fancy like an PA angioplasty or a sleeve, but still, I mean, there will be a chance of a pneumonectomy going in. This is a 71-year-old man, and therefore, pneumonectomy is not without any morbidity. So my personal approach to this would be to give these patients neoadjuvant therapy and reassess them after a short course of treatment. I would not go all the way to 4 cycles of chemotherapy, for example, or 4 cycles of chemo IO, but have a short term, like say after the second cycle, reassessment of these lesions.
Great.
Yeah.
Well, that's very insightful. And certainly when I was a resident, I had the fortune of training with Dr. Mulder, and this would have been a 58-minute left pneumonectomy, and somehow the patient would have done great. And I'm sure that would be true in your hands as well. But after tumor board discussion, we offered this patient chemo IO on trial, and this was post-treatment scan. We did exactly as you suggested and got a scan after cycle 2. And you can see that the tumor's still abutting the main PA, but it seems to be a little encroaching a little less. It's not by no means a complete radiographic response. I guess now the question is, what would you be thinking? Would you want to continue treatment, or have we achieved what we wanted and go straight to surgery with maybe a plan for adjuvant? Or would you still maybe even consider non-surgical therapy? A patient's doing well. What do you think?
Well, I think the plan was to give him 4 cycles of chemo. Was it chemo or chemo IO? Oh, you gave him chemo IO.
Yes, yeah.
So the plan was 4 cycles, and I think it's working. So I'd stick with the plan.
Well, yeah, I agree. And that, I think one of the things that comes out from any of the trial data in the chemo IO space is that you don't really know what this is, right? This could just be fibrosis, and it's so it makes we're in such a tough position now as to how to make intraoperative judgments about this. Yeah. Well, so that's what I did. I said, let's continue. And I like to see them either after their second or third cycle, so I can chat a bit about how they're progressing or hopefully responding, and discuss the surgical plan in more detail. And so I booked this patient for surgery. And then I think a week later or a little less, I got a call from the oncologist saying, slow down, cowboy. I don't think you saw the whole scan. And indeed I hadn't. And this was an error on my part. I missed this lesion down here, and there was another one sort of next to it. So what do you think about this, Dr. Al-Torki? How would you reevaluate in light of this?
Was this PET active?
Well, we didn't. This was the post-cycle 2 CT. It wasn't so we didn't have that information at the time. Well,
I don't know, which seems sort of odd for him to have just a solitary lesion in the right lower lobe like that, or maybe one next to the other like that. Mm-hmm. I mean, my experience is that with IO, sometimes you get granulomatous responses within other areas of the lung. So if I was not going to operate on this guy because of this, I would certainly make an attempt to have a needle biopsy or some documentation of metastatic disease.
Yeah, fair. Fair enough. I mean, we talked about it, kind of shared your thinking that it's a bit of a weird pattern of progression, even though it's not impossible. And so we decided just to continue treatment to complete the full course of chemo IO, because that would be what you'd sort of do in a metastatic setting. And although we don't routinely get PETs, this was off protocol. We decided to get a PET post cycle 4, and this is what it looked like. You can see that the lesion itself is still very avid, but that area completely resolved with no lesion to be seen on CT, so evidently something inflammatory. So I think the collaboration between the two teams was really essential. I'm curious to know about what your restaging policies. I get a lot of questions about, is imaging sufficient, or should we be doing invasive mediastinal staging after induction treatment? What are your thoughts on that?
Well, I mean, it's I think in somebody like this, who in 71 or 72 years old with a reasonable probability of having a pneumonectomy, I would probably have mediastinal staging done at the time of the planned operation. My suspicion, though, that in the absence of PET activity within the mediastinum, that he will have no evidence of mediastinal nodal spread.
Yeah, fair enough.
Yeah, the other thing, and I think there is something that of a controversial position, which is, what happens if you have residual N2 disease? Well, to my mind, if you have residual N2 disease and you have a lobectomy done and an R0 resection done, that's all well and good. I mean,
Right.
It becomes problematic if you have residual N2 disease and a pneumonectomy, but that's another discussion.
Yeah, that's fair. And that's my attitude as well. I don't personally get invasive mediastinal staging after induction if the initial one was negative, or the imaging continues to look like resectable disease, especially, as you say, especially if it's only going to be a lobectomy. But it is a continued matter of debate. So on to the next case. This is another patient, a 69-year-old woman, 30-pack year, ECOG 0, very fit, no comorbidities. She presented, however, with an advanced lesion. It was clinical T4N2, single station in the 4R position. It was squamous cell carcinoma as well. PD-L1 was 90%. We had a chemo IO trial for her, but she declined it because it was far from the hospital, and she didn't want to do the back and forth. You can see that this lesion is sizable. It's extending close to the hilum, and so she elected to. She was offered chemo radiation as an alternative, but she really wanted a surgical option, and so she went on to have conventional chemotherapy. After her first cycle of treatment, unfortunately, though, she presented to the hospital with febrile neutropenia. She was pancytopenic, and she needed a 1-week admission to the hospital. So what would you do in this scenario, Dr. Altorpi?
I think that one is now, I don't want to say committed, but she's failed. She's gotten the first cycle, and she obviously didn't do well with it. And your options are local therapy here. So I am, if she was, how old was she?
She is 69.
Yeah, so I'd say she's a young 69-year-old. I would probably operate on her and take this out and hope that I can give her adjuvant therapy, adjuvant IO at least.
Right. Yeah. So again, that's what we did. We did get a restaging CT just to make sure she hadn't progressed after that 1 cycle of chemo. If anything, it looked like the tumor had a partial response. And we went on to surgery. Though she had fortunately enlisted in our prehabilitation program from the initial visit, and so she continued on that for about 3 weeks after her discharge from the admission for febrile neutropenia. And I think it helped her get back to as close to her baseline as possible, though she was a bit beat up by the whole experience. We were able to do this by VATS lobectomy, by lobectomy rather. The tumor was invading along the superior pulmonary vein and pericardium. We had to do an intrapericardial revision of the vein. But the surgery was done by VATS and she was discharged on post-op day 2. It's embarrassing for me to show this stuff, but anyways, it's reality. Her post-op path was YPT4N2, and unfortunately she had an R1 resection. I was surprised because the bronchus seemed clean, but there was extensive LVI. And so the bronchial margin was microscopically positive, and we had a close margin on the pericardium. She was well after surgery. So now we get into this discussion. Patient has sort of failed chemo, had a near-death experience with it in the pre-op setting. What do we do with her now that she's back at baseline in terms of managing her adjuvant care?
Yeah, so, number one, I would not have expected her to have a positive bronchial margin based on the imaging that you just showed, but I guess it's possible that everything is possible. I think, it's a very unfortunate case because she is now outside of the evidence-based data that we have. It's important to know that the adjuvant IO is from Empower 010 is in patients who are completely resected. So by definition had R0 resection, which she does not meet that, and then had up to 4 cycles of adjuvant chemotherapy. She does not meet that. And then they can get adjuvant atezo. Mm-hmm. So based on the data, she would not be a candidate for adjuvant IO, but she's obviously has, on the other hand, no other options. As you know, the lung art study showed that there was, the lung art was actually in completely resected patients as well. So she does have a positive margin. I don't know. She has tumor expressed PD-L1 in 90% of its tumor cells.
Yeah.
So it'll have to be a discussion with the patient about whether or not she'd be willing to get treatment outside of a clinical trial.
Yeah.
I don't know of a clinical trial that addresses this specific situation.
Yeah, well, it's one of the reasons why I wanted to present it, because it's a difficult scenario, right? You kind of want her to get IO. You have every reason to believe that she would benefit from it. I think R1 on a bronchial margin is probably one of the last indications for adjuvant radiation or any microscopically positive margin. So that's what we recommended to her. And in Canada, anyways, we don't have access to adjuvant IO yet, but I would hope that some trial will offer this.
Yeah. So would she be a candidate for adjuvant durva after that in Canada?
That's an interesting question. We didn't explore that, but she'd be well, that's an interesting point. Okay, and now here's one of your cases, Dr. Al-Torki.
Yeah, so this is I present this case to make 2 points. So this is a fellow that presented with a pretty large, I think it was almost like a 10 or 11 centimeter tumor in the lower lobe, and clearly heading towards a pneumonectomy based on the extent of his local disease. The biopsy was positive for adenocarcinoma. He was a former smoker. We had at the time our neoadjuvant durvalumab plus low dose SBRT of 8 gray times 3, and we gave him the first cycle of treatment. So he gets 8 gray times 3 in 3 consecutive days plus 1 dose of durvalumab. And then he came back for his second cycle of treatment, and he had grade 3 transaminitis, or his AST and ALT were really elevated. And, we were stuck. We imaged him, and the image is what you see in the middle there. So he had a significant partial response after 1 cycle of that treatment. But we were unable to operate on him right away, or we decided not to operate on him right away until his transaminitis resolved. There was no treatment given, and we waited about 4 weeks afterwards, I think week 11 or so, that we operated on him. and he had actually a lobectomy, if you can believe it, and had major pathological response with less than 10% viable tumor cells in the resected specimen, and his nodes were negative. So to me, that's, it was a spectacular case from my point of view, in the sense that I would not have expected that we would be able to avoid an immunectomy in this person. And then the issue of transaminitis, which, as I showed earlier, is pretty common. And it's often transaminitis and not hepatitis, meaning he wasn't clinically sick. So these are the two issues. And I don't know, I mean, I suspect if you would have seen him, you would have given him neoadjuvant therapy rather than operate on him right away.
Yeah, for sure. In our practice, that's what we would have advocated. I like the idea of a chemo-sparing regimen like this that you've published in your trial. Have you noticed any issues around bronchial stump healing? There is some data around the use of preoperative radiation, especially for hilar lesions. Is this something you've encountered?
Not really, Jonathan. This is really low dose. It's 8 gray times 3, which is equivalent to about 24 biologically effective dose. So much less. It would not ablate the tumor, let alone cause any problems with healing.
Yeah, so it's really inducing, sort of assisting the immune response. Really. Yeah. An immune adjuvant.
Let me ask you, in the chemo IO setting, if you guys have things like transaminitis or any other immune-related adverse events, who manages that? Do you manage that? Does the oncologist manage that, whether it's pre or post in the adjuvant in the postoperative setting?
So, in the preoperative setting, it's obviously the oncologist, and we have a sort of immune-related adverse event team of rheumatologists and immunologists for complicated cases that our oncologists can't manage. I think in the postoperative and surveillance portion of the treatment, I think for the surgeons, it's more a matter of awareness and detecting things that might be subclinical. I had one patient who got Ipi/Nivo, had a path complete response, and I saw him 3 months after surgery, and I was hoping that he'd be excited about the great outcome he was having. He was so depressed, and it was only after a bit of digging and we figured out that he was profoundly hypothyroid, and that happened just after, I think, 1 or 2 doses of Ipi/Nivo. So I think it's an awareness of those things that we need to have, so that we can help identify issues as they emerge along the course of the patient.
I think you're absolutely right. The other thing that we need to be aware of is the chances of immune-related adrenal insufficiency in the immediate postoperative people, because period, as you know, this can be sort of like not exactly something that comes to mind right away, and you may run into issues of hypotension and the like.
Well, it's very fortuitous of you to mention that, because we have a case about a very one such scenario. So if you don't mind, we'll go on to the last case.
Sure.
So this is a 48-year-old gentleman who presented with ECOG1. He was a heavy smoker. As you can see, this is a very large tumor. We staged it as a T4N0 after CT, PET, and EBUS. It was a non-small cell lung cancer, not otherwise specified. There was no mutations on a 52 gene panel, also had a high PD-L1. And there was almost complete occlusion of the SVC. The tumor was abutting the first, second, third, fourth ribs, extending to the innominate vein and innominate artery, or at least abutting it. His FEV1 was 57%, the LCO was 54%, so a little bit borderline. He had some facial swelling and right shoulder pain. So, very locally advanced disease. You can see that the tumor is almost closing in on that bronchus and the first branches of the pulmonary artery. We discussed him at our tumor board and felt that his his radiation fields have been very extensive for a curative chemo-RADS plan. And in order to get access to chemo IO, we deemed him unresectable and sort of treated him as metastatic. And we were able to get access to chemo IO, for which we had a plan to give 4 cycles. We restaged him after 2 cycles, and this is the tumor where you can see some necrotic areas emerging. You can see the bronchus sort of opening up a little bit. There's the first branch of the PA there that looks clear. His facial swelling resolved, and you also see massive collaterals all along the side of the chest and along the diaphragm, indicating that his SVC closed off and that he collateralized during this neoadjuvant period. These are the images along the innominate artery and chest wall. So we continued on with 4 cycles of chemo IO, and there was an issue with surgical timing. The patient lived quite far from our treatment center. And just for convenience, we gave 1 more cycle of IO monotherapy to get the right plan. We approached him with the right sternothoracotomy. It was an extremely bloody opening due to the SVC syndrome, but we were able to get control ultimately. And as we were dissecting, we were surprised that the parietal pleura was sort of clearing. I thought there'd be rib involvement. Sent some frozen sections from that, and all was coming back negative. I was expecting to have to do a bronchial sleeve, but we were able to dissect right onto the upper lobe takeoff and cut it flush with a knife, and sent the whole specimen off for frozen section. Surprisingly, I was shocked. The pathologist told us that the bronchial margin was negative. Our PA dissection was actually quite easy, approaching it from intrapericardial. At the end of all of this, it was a YPT0, N0, and an 8 centimeter necrotic tumor bed. So Dr. Altorki, what do you think about this? How do you approach patients post-chemo IO with the idea of the operation you offer them? Are you thinking you're basing it on the original scan? Will you tailor based on what you find intraoperative? I think one of the issues we're going to face moving forward is how do we tailor our surgery to the unknown response that might be happening pathologically?
Yeah, so well, number one, this is just a totally spectacular case. Congratulations on getting it done. It's really a tough case, and the fact that he had a complete path response is fantastic. And I think in the end, obviously he's better off with that thing out than in. I've always based the operation on the original image, although I think that pertains mainly to the era of neoadjuvant chemotherapy or neoadjuvant chemoradiation. In this new phase, I'm not quite sure. I mean, I think we're all learning here, and the part of the problem is sometimes the response to chemo IO is dense fibrotic response, and it is very hard intraoperatively to make a decision about whether or not you're dealing with tumor or not. And sometimes that leads you to do more rather than less. But obviously, from your trial results, it seems like less pneumonectomies were done in stage 3A. So that's not really a robust finding, but it's something to think about.
Right. Yeah. So, the other thing is that this patient's postoperative course was not smooth, and you raised the issue of adrenal insufficiency. This guy developed pneumonia, rest failure. He was hypotensive, and although his sepsis improved, his hypotension only resolved after we gave him some steroids, which is sort of compelling for adrenal insufficiency. And you wonder if the pre-op IO could have triggered that. So he had a tough course. He eventually made it home and was relieved. But do you think that if we were able to predict the event of path CR, that it would be better to avoid surgery and consolidate with radiation? I'm sure we're going to be pressed for that question in the near future as well.
Yeah, I don't know that you can predict it. I mean, I think that most of the time there is more metabolic activity on PET, or at least residual metabolic activity on PET, from the infiltration of the tumor mass by all these active immune cells.
Yeah.
In this instance, I'm not quite sure how you would have avoided that. But it's certainly an operation that you did there, Jonathan.
Yeah, well, I think one of the fun things about this is that it does create a lot of opportunities for us as surgeons, maybe opening the possibility of offering good things for our patients, which might not have been doable in the past. So one more case here discussing periadjuvant therapy. We have a 55-year-old Asian American gentleman with an extensive smoking history. This patient presented with hemoptysis. His chest X-ray showed a right upper lobe mass, was then confirmed by CT to be 4.9 by 4.1 by 2.7 centimeters in the right upper lobe, with a solitary size significant lymph node in the right hilum. Brain MR was negative. PET was otherwise unremarkable. Patient was taken to surgery for right upper lobectomy. Path showed an R0 resection with lung adenocarcinoma. It was PD-L1 70%, EGFR, ALK, and ROS were negative. KRAS G12A mutation was identified, and as I said, only one positive lymph node, so really a T2B and 1. Patient went on to get 4 cycles of adjuvant cisplatin pemetrexed, which he tolerated very well, except for some mild neuropathy. So what are your thoughts? I think key features here are the hemoptysis, the PD-L1. How would you recommend this patient get treated?
Well, I mean, I think prior to Empower 010, this patient would have probably been treated by surgical resection followed by adjuvant chemotherapy.
Yeah.
And I think now the data are compelling, I think, for, what did you say his PD-L1 was?
70%.
Yeah, I think the data now are compelling that this patient should get adjuvant atezo after he finishes his adjuvant therapy. This is exactly what Empower 010 is about here. He fits the bill completely.
It's a slam dunk, and it's a testament to the importance of the biomarker testing on some patients. Some of the questions that come up as we close here from folks in the audience who are listening are around the endpoints, EFS, DFS. Some have concerns that, we're in the curative setting, that we really should be benchmarking to OS benefit. Do you have thoughts about that and how to interpret some of these early trial results?
Well, yeah, I think that I'm an advocate for DFS. I mean, there are so many alternate therapeutics now for patients with lung cancer that if you really want to address the efficacy of a therapy that you're delivering, I think DFS is an important endpoint. I think it's an important endpoint for the patient as well. And I think the FDA is approving agents based on DFS more and more. So not to diminish the value of overall survival, but I think, for a long time, we've sort of diminished the value of DFS. And I think it's something that we should keep in front of mind here.
Yeah, I couldn't agree with you more. The last question is this concept of team building and being able to work with a community of experts. Do you have any advice for practicing surgeons out there who may not have employed these kinds of perioperative treatments as much as they may in the future, in terms of operationalizing collaborations between specialties, between sites, because we're often working across hospitals?
Yeah, I think, I think we've already shown that in a multidisciplinary setting, patients do better, regardless of what the therapy is, whether it's chemo-IO or chemoradiation or chemotherapy or just surgery. I think if there was ever a reason to continue sticking to the concept of multidisciplinary tumor boards and multidisciplinary engagement. I think it's really important. And the other thing that I would say also here is that the issue of molecular testing of tumors in early stage disease, this is now front and center with the results of this trial that you had, and Empower 010 and the ADORA trial. These things have to be done up front and have to be discussed in tumor boards, and decisions have to be made because they're proving to be important for outcomes.
I couldn't agree more, and this is, I think, could be a better way to close this session. Dr. Altorki, thank you very much for the opportunity to do this with you. As you know, I hold you in great admiration, and it was fun. So thank you very much.
Great session. Thank you.
Take care. Bye, everyone.
Bye.
This activity is certified by Medical Learning Institute, Incorporated. This activity is developed in collaboration with our educational partner, PVI, Peerview Institute for Medical Education.